So good afternoon, everyone. I would like to start by reminding everyone that after the talk today, there will be a reception in the Clinical Center Library, so I hope that you can join us there. My name is Vince Bonham, and I'm an investigator in the Social and Behavioral Research Branch in the Intramural Division of the National Human Genome Research Institute. And I'm honored today to have the opportunity to introduce you to Dr. Lisa Cooper. Dr. Cooper is a professor of medicine in the Department of Medicine at Johns Hopkins University School of Medicine. She is a member of the core faculty of the Welch Center for Prevention, Epidemiology, and Clinical Research, and is a member of the faculty of the Health Policy and Management Department and the Health Behavior and Society Department at the Johns Hopkins Bloomberg School of Public Health. She received her Bachelor's of Arts degree at Emory University and medical degree from University of North Carolina at Chapel Hill, followed by a Master's of Public Health at Johns Hopkins University School of Public Health. Dr. Cooper's research focuses on patient-centered strategies for improving outcomes and overcoming racial and ethnic health disparities in healthcare. She has conducted several observational studies to explore and better define barriers to equitable care across racial and ethnic groups and mechanisms for disparities in health status and health care. Dr. Cooper was the principal investigator on 2 randomized trials funded by NHLBI and ARC of interventions to improve quality of care of outcomes for patients with hypertension and depression in primary care settings. She is currently the principal investigator of the Center for Population Health and Health Disparities, the Hopkins Center to Eliminate Cardiovascular Disparities funded by NHLBI. Dr. Cooper's research links the patient and clinician attitudes and behaviors with health outcomes. Her work continues to inform the training of physicians and institutions in which they practice to deliver high-quality, equitable care to increasingly diverse patient populations. She's received numerous honors and awards, including a Fellow Award from the MacArthur Foundation, commonly known as the Genius Award. She is a member of the National Academy of Science Institute of Medicine, a Fellow of the American College of Physicians, and received the Herbert W. Nickens Award for exceptional commitment to cultural diversity in medicine and improving minority health from the Society of General Internal Medicine. Dr. Cooper was born in Liberia and attended high school in Switzerland. Her father was a surgeon in Liberia, trained in the United States, and during unrest in Liberia, her family moved to the United States. Dr. Cooper said, and I quote, "I grew up around people from a lot of different backgrounds. Throughout my career, I have strived to understand how patients and physicians from different racial, ethnic, and social backgrounds can learn to relate and work with each other to achieve better care." It is my honor to introduce Dr. Cooper.
Thank you so much for that warm introduction, and it's great to be here today. We could be outside in the 70-degree weather, I realize. So I'd like to start out with an overview of the lecture. First, I will spend just a short amount of time describing what I call the problem of disparities in health and health status between racial and ethnic groups in the United States. I'd like to spend most of the time talking about how we understand the mechanisms for these disparities, with a particular focus on relationship dimensions in healthcare that may be linked to disparities. And then finally, we'll spend a little bit of time talking about interventions that I've worked on with my colleagues that are aimed at the improvement of race relationships as a strategy to overcome disparities, and then end with conclusions and implications. So many people may already know this, but for those of you who haven't been focused on this, you may be wondering, what are health disparities? Well, a health disparity population is a population where there's a significant disparity in the overall disease incidence, prevalence, morbidity, mortality, or survival rate in the population compared to the health status of the general population. And early in the 21st century, The Healthy People 2010 indicated that certain groups of individuals were considered to be part of health disparity populations. You can see that disparities occur by gender, race, ethnicity, income, disability, geographic location, or sexual orientation, and we're going to focus on race and ethnicity today. And what do we know about health disparities? Well, we've been studying this for over 100 years, and probably even more so in the last 30 years. We know that they are extensively documented. They exist for all the common population health indicators, including life expectancy at birth, infant mortality rates for the overall population, as well as sickness rates. And they seem to exist for ethnic minority groups relative to whites almost across the board for so many different indicators, although they may differ for specific diseases or specific subpopulations. We also know that health disparities result from complex interactions among multiple factors. And these factors are often differentially distributed across the population, across different population groups. These are biologic factors, cultural, socioeconomic, environmental, psychosocial, as well as health risk behaviors. And finally, access to care and quality of health care are all believed to interact and contribute to health disparities. I've highlighted access to health care and quality of health care because that's the topic of our lecture today. So what are health care disparities? We started out talking about disparities that exist in health and out in society, but what we came to know over the last decade or more is that, in fact, even within healthcare, there are disparities in care that exist. And the IOM report, Unequal Treatment, which many of you may be familiar with, was published back in 2003, and that report actually came out with the following definition. Healthcare disparities are differences in care that result not from differences in access or clinical appropriateness or patient preferences, but rather from discriminatory processes within the healthcare system, or from bias and prejudice, stereotyping, uncertainty, communication, and clinical decision-making problems between providers and patients. Now, I just want to clue you into the fact that this statement was made based on a lot of indirect evidence, because what the IOM report did was reviewed decades of literature documenting that healthcare disparities were pervasive and could not be explained by differences in access and patient preferences or clinical appropriateness. In fact, what they found was that these differences in care existed across conditions, across populations of patients, existed in numerous care settings, across levels and types of care, all the way from the most simple, basic type of diagnostic test to the most complex type of procedure. And so we're thinking about things like just getting, for example, a pap smear in the doctor's office, or a blood test or a urine test or something like that, all the way to getting organ transplantation or getting a cardiovascular procedure or bypass surgery. The other thing that the IOM report found in its review was that if you think about how healthcare quality is conceptualized as having these different dimensions, including access, timeliness, effectiveness, safety, patient-centeredness, and equity, you saw that there were disparities between ethnic minority groups and Caucasian groups in healthcare. Around the same time that the IOM report came out, my colleagues and I were working on a model that would help us better understand what some of the potential mechanisms were for these disparities in healthcare, as well as maybe provide us with a framework for developing interventions. And what we found, this is a very complicated diagram, was that basically there are barriers in access to care that exist on the personal or family level for patients, as well as structural barriers within the healthcare system and financial barriers, and that all these barriers actually impact on the use of services, the type and setting of the service, and then once a patient gets into the healthcare system, there are several mediators of the care that they get, and that ultimately we care about all of these things because they do impact on health outcomes. The area that I want to focus on today is right in here where it says quality of providers. In the previous model of access to health care in America, there was not as much emphasis on particular qualities of providers. And some of the areas that we expanded upon in this model included the cultural competence of the provider, as well as their communication skills and their likelihood of either engaging in biased or stereotyping behaviors when interacting with patients who were from diverse groups or groups that were different from the providers themselves. And one of the reasons to focus on providers is basically because interactions between patients and providers, as well as other individuals in the healthcare system, are the central situation in which patients are diagnosed, given treatment recommendations, referred for lab tests or procedures, or referred to consultants. So in order to actually do anything in healthcare, you have to have some relationship with another person. And so we're going to focus on the quality of relationships between patients and providers. What do we know about this? Well, one of the reasons we know this is important, we sort of, it's intuitive to us that that would be important, but there had also been growing evidence that the quality of the patient-physician relationship is related to important outcomes. So outcomes such as the patient knowledge of their condition and recall of the information they were given, their adherence to recommended treatments, their satisfaction with their care, as well as to clinical outcomes. And in particular, pain reduction and depression resolution are the clinical outcomes for which we have the strongest evidence that the quality of relationships in healthcare matters. What little was known about was how these interactions, these relationships across racial and ethnic lines might be playing a role. So I thought I would share with you a couple of quotes that sort of really exemplify some of the issues we're talking about today. This is what one of the physicians in a study that I did had to say. He said, "I think it is more difficult to manage someone of a different culture. They may have different values. I often wonder if there's something else that either the patient hasn't told me or that I'm just not understanding." And he was talking about, this was a white primary care physician talking about his African American patient. And now I'll share with you two quotes from the patient perspective, one that is positive and one not so positive. So on the positive side of things, this African American woman with depression said, "The doctor I have now is great. He's nice and calm, and he asks a lot of questions. I think he's very, very sharp. I think whatever this guy tells me for the most part, if it sounds sensible, I'll give it a try." On the flip side of that, you can see where this African American man who didn't have such a great relationship with his physician said, "Do I believe this doctor? Do I trust that doctor? Are they just giving me medications just to throw them at me?" So you get to a point where you don't actually take the medication. Now, there are several dimensions of relationship that may have potential links to disparities in healthcare quality, but I've chosen to focus on 6 of them today. And they're very much interrelated. So we'll start out first by talking about communication. These are the behavioral actions through which all other relational features are observed. Second, partnership, which is a union that values the unique perspective, knowledge, and participation of each person. Concordance, which is shared identities between patients and clinicians. And this may be across visible dimensions such as race, gender, or age, and across less visible dimensions. So just things like beliefs, values, preferences. The fourth dimension that I'll talk about today is trust. This is the degree to which one believes that another person is competent, caring, responsible, and ethical, and will act in one's best interests. Respect, which is the recognition of each person's inherent value. It's an attitude of unconditional positive regard. And then finally, bias and stereotyping. These are preconceived judgments or opinions about someone or a group of people. We want to note that bias and stereotyping may be held by anyone, could be held by clinicians or patients. For the sake of this lecture, we're going to be talking about the influences of clinician bias on healthcare quality. So I'll start out by telling you somewhat of a story. It's just a journey of sort of my scientific inquiries in this area. I started out early on with a study that was called Race, Gender, and Partnership in the Doctor-Patient Relationship. And remembering that partnership is one of the important dimensions of relationship. And what I did was I conducted a telephone survey with my colleagues of adult attenders of primary care here in the Washington, D.C. metro area. And we were able to survey over 1,800 adults who had just been in to see their primary care physician. There were 65 of them in the last 2 weeks, and to ask them questions about the quality of care that they received. We were hypothesizing that race and gender concordance between the doctors and the patients would be related to an important measure of the quality of relationship that we called participatory decision-making, or PDM style. Now, how do we measure partnership or participatory decision-making style? We used an instrument that was developed by Sherry Kaplan and colleagues, where patients were asked to respond to these 3 questions. If there were a choice between treatments, how often would this doctor ask you to help make the decision? How often does this doctor make an effort to give you some control over your treatment? And how often does this doctor ask you to take some of the responsibility for your treatment? Each question actually contributes 33.3 points for a total of a 100-point score on this scale. So a higher score means that the doctor was more participatory. We found that ethnic minorities rated their visits with physicians overall as less participatory than white patients. That included African Americans as well as Hispanic and Asian primary care patients compared to white patients. And although there was only a 3 to 4 point difference between the minority group and the white group, it turns out that in a previous study that used this measure, a 4-point difference in this measure was related to a 10% increased likelihood that the patient would switch doctors in 1 year. We also found when we looked at race and gender concordance that patients who were in race concordant relationships rated their physicians, race discordant relationships rated their physicians as less participatory. There was a similar pattern for gender discordance, but it didn't achieve statistical significance. And this was true even after we adjusted for a number of different potential confounders, such as the patient's age, gender, marital status, health status, and their length of relationship with a physician. We then became interested in understanding what was going on in that black box of the doctor-patient encounter. Was it just that patients perceived that there was less partnership, or could it be true that the communication in the encounter actually differed? So we conducted another study, patient-centered communication, ratings of care and concordance of patient and physician race. We went to primary care practices in the Baltimore and Washington area, and we sought practices that delivered care to diverse patient groups. And we also sought practices in particular where physicians of different race and ethnic groups practiced within the same practice. We recruited 31 primary care physicians and over 250 of their adult patients. You can see 110 whites, 142 African Americans from 31 primary care physicians. They were in 15 urban primary care practices in the Baltimore, Washington area, many of which were federally qualified community health centers. Our main predictor variable we were interested in was the race concordance in the doctor-patient relationship, and we were interested in looking at outcomes that included communication behaviors as well as patient ratings of care. To measure communication, we used a coding scheme called the Rotor Interaction Analysis System, or the RIAS. This system is a well-validated way of measuring communication, has been used in numerous studies in primary care and other settings. What happens is we have coders who are trained to listen to audio recordings of visits and to classify every statement that's made by the doctor or the patient into one of 37 mutually exclusive and exhaustive categories. The categories may be considered to be content-oriented, affect-oriented, or process-oriented. For content-oriented statements, they may be either of a biomedical nature or of a psychosocial nature. And these statements may be related to gathering data, such as even asking questions, or they may be information-giving statements. The affect or rapport-building statements are more statements that are related to the emotional nature and the relationship-building piece. There's emotional talk, there's positive and negative talk. Positive talk is laughter and compliments that might be exchanged between the doctor and the patient. Negative talk, disagreements and criticisms. And then you have social chit-chat, which also falls into rapport building. And then the process-oriented statements are just orientation statements about the flow of the visit, for example, or facilitation statements where the doctor is actually trying to engage the patient in the decision-making related to his illness, or basically trying to make sure the patient understands and is following what's going on. So here are a few examples. So biomedical talk focuses on, for example, a biological measure like blood pressure, or the patient says, I was in the hospital last year for ulcers. For psychosocial talk, it's usually about family relationships, jobs, things that aren't specific to the disease, but so you can see here what the doctor might say and what the patient might say. Rapport building, again, empathy statements, statements of concern or worry, any kind of self-disclosure, statements of encouragement. And then partnership building, you can see the doctor might say to the patient, are you following me? And how does that sound to you after discussing a treatment plan? So we created some composite or summary communication measures from all of those individual categories of talk by the doctor or the patient. And these are the measures that had been in use in other communication studies, but hadn't been looked at across race and ethnicity. So verbal dominance, which is measured from the doctor perspective, the doctor is being verbally dominant if you measure all doctor talk and divide it by all patient talk, and you come up with a number that's greater than 1, that means the doctor was verbally dominant, versus if it's less than 1, then the patient was verbally dominant. Patient-centeredness is also another ratio. So it's created by adding up the psychosocial and emotional and partnership talk and all of the patient questions, and then dividing that by the biomedical and procedural talk. And so again, if patient-centeredness is greater than 1, that means the visit was oriented more towards the patient's agenda, whereas if it's less than 1, it means that it was oriented more towards the doctor's agenda. Then we have affect ratings. So the coders are actually also asked, in addition to coding the verbal content, to just listen to the voice tones of the doctor and the patient and to give overall ratings on voice tone quality at the end of listening to the tape. So what we do is we sum up the coder ratings of the doctor's assertiveness, interest, responsiveness, and empathy, subtract it from the coder rating of how hurried the doctor sounds. And we create a measure called the physician positive affect. And the patient positive affect is created similarly, except there's no rating for patient hurriedness because patients are never hurried, or almost never hurried. And then we have the visit duration, which is the length of the visit in minutes, and the speech speed, which is basically adding up all of the talk in the visit and dividing that by the length of the visit. So what did we find? We found that communication differs in the visits of African American and white patients. So physicians are verbally dominant with patients. You can see the verbal dominance ratio is greater than 1 for both white and black patients. However, physicians talk 50% more than white patients and 73% more than black patients. Similarly, the patient-centeredness ratio was somewhat higher for white patients than black patients. And patient and physician-positive affect were both higher in the visits of white patients than black patients. And this was true after adjusting for a number of different patient-level potential confounders, as well as physician-level variables that might have been differentially distributed across groups. These findings were true regardless of the race of the physician. When we looked at race concordance, however, we did find some interesting but other communication differences. So we found that patients in race discordant relationships had shorter visits with their physician. So we didn't actually find differences in the content of the visit, but more differences in the length of the visit, about 2 minutes shorter when there was a difference in race between the doctor and the patient. And also the patient was being rated lower in terms of positive affect in those visits. There was also a pattern whereby both the doctor and patient were speaking more rapidly in the race discordant visits. And we thought, at least at that time, that that was an indicator of anxiety or discomfort, and that this longer visit might indicate something positive. And it turned out that that is likely to be true in this particular case, because we found, similar to what we found in our earlier study, was that patients in race concordant relationships actually rated their visits better, and in race discordant visits rated their visits more poorly overall. The other thing relationship dimension that I wanted to examine in some of my work includes trust. And so this data, comes from a survey of Baltimore City residents, where we did a telephone survey asking patients about, basically we were asking them about willingness to engage in different types of treatments in medical care, and whether or not, and finding out what their levels of trust were. And what we found was that African Americans, when compared to whites in Baltimore, had less trust in physicians as well as in hospitals. And in particular, the African Americans had more concerns about their privacy being invaded and about being experimented on in a harmful way. And now this has been replicated in a number of different studies across the country, as well as national surveys. So this is not entirely surprising, but again, you can imagine a very critical aspect of relationship that could be contributing to disparities. We know that trust, for example, is associated with patient adherence and associated with positive outcomes. The other thing we found, this is a large survey conducted by the Commonwealth Fund, national survey of household residents, looking at perceptions of treatment in the healthcare system. We found that ethnic minorities report more biased treatment by health professionals. Now, this was true across all ethnic minority groups, and we asked them things like, do you think you would have received better care if you were of a different race or ethnic group? Were you treated unfairly based on race, or treated unfairly based on how you speak English? And across the board, minority patients felt that their care was biased. So that's from the patient's perspective, but we're interested in understanding whether, in fact, is this really true, and what is it that physicians might be doing that would lead to patients feeling that their care was biased. So we know that bias can be explicit or conscious. It could also be unconscious or implicit. And what we know about explicit bias is that it's decreased over time on a societal level. However, there's still many individuals that do have explicit biases that are not considered to be socially, they're considered to be socially acceptable. So for example, there's a sample of physicians in this study who actually, when asked specifically how they perceived certain patients, were willing to say that they perceived Black patients as being less intelligent, less educated, and less likely to adhere to treatment. On the flip side of this, though, there are these unconscious biases that we have, and this has been sort of documented by social scientists and social psychologists. What we know about a lot of these unconscious biases is that they are learned very early through our cultural socialization. So, for example, we learn very early to associate certain attributes with certain population groups, just like how we learn to categorize inanimate objects, things like apples and oranges, and group them together as fruit, for example. So some of this is just the way that our brains simplify a lot of the information that's coming at us. What we know about implicit attitudes from the social science literature is that they do tend to have negative effects on behavior. This has typically been in very controlled laboratory experimental type settings. There have been a few studies that have looked at implicit racial bias among physicians. This particular one used a survey, a computerized survey of physicians in training, so residents, and asked them to rate hypothetical scenarios of patients coming in with cardiovascular complaints. And what this study showed was that when the more implicit racial bias there was, in other words, bias favoring whites over blacks, these physicians were less likely to refer a patient for a cardiovascular procedure. And although the patients in the scenario were exactly the same except for the race. What we didn't know up until this point was whether or not these implicit racial biases actually impact what goes on within the visit in real patients and in real clinical settings. So my colleagues and I set out to do another study where we were interested in looking at the impact of implicit racial bias on the patient-physician relationship. We did another cross-sectional study where we recruited primary care physicians who were participating in 2 other trials and asked them if they would be willing at the beginning of the study to take an online computerized test that would measure their unconscious attitudes about race. We successfully recruited 40 clinicians who were ethnically diverse, and over 200 of their patients, African American and white. These were patients in primary care settings in the community from urban practices in Baltimore. Now, our main predictor variables were 2 different implicit association tests about race, and I'll tell you more about those now. Well, actually, right after I tell you about the outcomes. So we were looking at implicit racial bias, and then the main outcomes were the communication behaviors that I described to you before, as well as the patient ratings of relationship. And this just tells you the analytic strategy we used. So let me explain to you why we came up with these 2 tests. So the first implicit race bias test is one that I'll describe to you in more detail now, but it measures general race bias. It measures the extent to which individuals associate negative concepts with people who belong to African American ethnic group. This implicit race test actually is designed specifically for health professionals, and it tests the degree to which physicians link words that indicate compliance or adherence or cooperation with a treatment plan, and it looks to see whether physicians link those words differently for individuals belonging to different racial or ethnic groups. So it's called the implicit race compliance stereotype. So the reason we did these 2 tests is because we know that general race bias would influence communication negatively overall. But we wondered whether there was more of a specific stereotype within healthcare that might be influencing health outcomes in a different way. So we hypothesized that the general race bias would affect mainly the socio and emotional type communication, whereas the compliance stereotyping bias would influence more of the task-oriented aspects of the visit because, clinicians might be trying to promote more adherence among patients who they had an implicit stereotype about. But we thought both of these types of bias would have a negative impact on patient ratings of relationship. So let me tell you about the implicit association test. Many of you are probably familiar with it. It was described in the book Blink, and now it's actually become a fairly popular test on the internet that thousands, hundreds of thousands of people have taken. So it's a computer-based indirect measure of social cognition, measures the time that it takes respondents to match representatives of social groups with certain attributes. And the premise is that individuals will link concepts that are more strongly associated more quickly when completing a computerized task. The race IAT in particular asks participants to sort and pair African American and European American faces with words as they appear rapidly on a computer screen. And I'll demonstrate this to you briefly, but basically the IAT score is a difference in average response time on 2 tasks. So the first task would be a task where a respondent is asked to match good words and black faces and bad words with white faces, and then subtracted by the time it takes them to match good words with white faces and bad words with black faces. So here's a brief demonstration of what this looks like. When you get on the website, you have the screen that says African American or European American. The instructions tell you to put your fingers on the E and I keys on your computer. The E being, on the left side, the I being on the right. And basically, if you see a concept in the middle of the screen that represents African American, you're to click on the E, and if you see an image in the middle of the screen that indicates something that would be European American, you would click on the opposite side. So for example, for this one, you would click on the left-hand side of the screen, for this one on the right-hand side of the screen. So then they introduce you to actually they put the words or the attributes on the screen, good or bad, and ask you to do the same thing. So what happens is a word will appear in the middle of the screen that should be associated with the attribute good, and you would click on the left-hand side, and then for awful, you would click on the right-hand side. Then what they do after this is then they say, okay, we're going to combine these two concepts. And so when the image appears in the middle of the screen, if it's a good word, a word associated with good, or if it's a European American face, we want you to click on the left, right? And if it's an African American face or it's a bad word, we want you to click on the other side, either or. So, you have to do this very rapidly. You can't sit and think. So, you would click on the left-hand side here, on the right-hand side, on the right-hand side, and then on the left-hand side. Then they flip the order around. And so now African American is paired with good, European American is paired with bad, and they see how quickly you can do the next series of tasks. So you can see here African Americans paired with good. How quickly do you hit the bar on the left-hand side versus right? Same with here, how quickly do you click the right side versus the left? And what you find interestingly is that if you have a bias that favors whites over blacks, you have a much harder time completing the second group of tasks than the first group. So the main outcome measures, again, were similar to the ones we used in our previous studies, looking at verbal dominance in the visit, patient-centeredness, positive affect, visit length, and speech speed. The other thing I didn't mention to you all is, by the way, these measures of communication have been linked to things like continuity of care and patient adherence, and into health status in a few circumstances. We also looked at patient ratings of relationship. We looked at ratings of respect, of liking of the clinician, of feeling whether the doctor liked the patient. We looked at ratings of confidence and likelihood of recommending the clinician to a friend. So what we found on the IAT scores was that 2/3 of our sample scored in the range of having a preference for whites over blacks, and that ranged all the way from a slight to a strong preference. Then in terms of the neutral or no difference between the performance time on the two tasks, that was only about 10% of the physician sample, and then a smaller proportion of physicians actually showed some sort of preference for blacks over whites. Understand that this is a relative preference, so nobody is saying that these individuals are prejudiced or that they don't like blacks at all. It's just a relative preference for whites over blacks and vice versa. This is similar, by the way, to what's been shown in the general population. So the overall population in the United States, about 2/3 of the population shows a preference for whites over blacks. When we look to see how the scores on implicit IAT related to communication, what we found is that a higher implicit bias scores indicates a preference for whites over blacks. And what we found was that as your implicit bias score increased, the patient's positive affect decreased among black patients, but there was no effect on implicit bias in the visits of white patients. As far as ratings of care, we found that as there was more of a preference for whites over blacks, that black patients rated these doctors lower on respect, whereas white patients rated them much higher. With regard to patient liking of the clinician, we found as there was a stronger preference for whites over blacks, that black patients reported less liking of their clinician, whereas white patients reported somewhat greater liking. We also found that as there was more bias favoring whites over blacks, that black patients reported less confidence in these physicians. White patients, a little bit less, not statistically significant. And then finally, recommendation of the clinician to a friend. Again, the more bias favoring whites over blacks, the lower the likelihood of recommending the physician to a friend among black patients. A slightly lower percentage among white patients, but not significant. So now I want to show you the results for the race medical compliance stereotype. So again, that test is very similar to the general race IAT, except the words that show up on the screen are not good or bad, joyful, awful, those kinds of things, or evil, but more along the lines of words that relate to being willing, compliant, adherent, trusting, that kind of thing, versus reluctant, mistrustful, those kinds of things. And so this test was developed specifically for use in health professionals. So again, similar to the general race IAT, you complete the different tasks, groups of tasks. If you respond more quickly to the pairings of the white compliant patient and the black reluctant patient, if you respond more quickly to those and then the opposite pairings, then you are said to have a compliance stereotype that favors whites over blacks. So what do we find here? We actually found some different effects on communication. And this was, some of it was somewhat surprising, but we found that if the physician had an implicit stereotype that favored whites over blacks as being compliant, that they actually spent longer, 20% longer time with black patients and less time with white patients. So they're spending longer. We also found that more of this stereotype was linked to slower speech with the black patients and faster speech with the white patients. Now recall what we said previously was that we thought visit length was something positive, and we thought the longer the visit would be, the better it would be, right? And we thought speech speed, if it's slower, it's probably better, right? In the race concordant groups, the patients seemed to really like that and be happy with it. Well, interestingly, we found here that as there was more of a stereotype, even though the visits were longer with slower speech, the black patients were not satisfied and didn't like it. And you may wonder why that is. So here's maybe an indicator of why that might be. When there's more of a stereotype favoring whites over blacks as compliant, physicians were slightly more verbally dominant with black patients, but much less verbally dominant with white patients. So even though they were spending more time and speaking more slowly, they weren't really allowing the patient to talk as much as they allowed white patients to talk. The other thing we found is that their patient-centeredness ratio was much lower when they had a compliant stereotype among black patients, and then that it was higher among white patients. So suggesting that even though they might be talking more slowly and spending more time, that the conversation was more geared towards the medical agenda and not towards the patient's agenda. So I'm going to transition a little bit now from the research findings just to talk about where are we going. We've been studying health disparities for years, decades. It's been on the national health agenda. But I would say since about a decade or so ago, the elimination of health disparities has become a national imperative. So we've made a lot of progress in terms of policy changes, allocation of resources, reports being published, encouraging research in different areas. We've made some strides in healthcare reform, that are likely to contribute to reduction of some health care disparities anyway. And this, in some ways, mirrors what's been shown in the evolution of health disparities research. So, we spend a lot of time describing the problem, and for the last couple of decades have really delved a lot into mechanisms. And while a lot more needs to be done, we're now moving into designing interventions and looking at outcomes, and also engaging communities, because what we're learning is that the interventions actually need to be informed by the communities that are impacted. So I'll just tell you briefly about one of the interventions that I've been involved in. This is called the Patient-Physician Partnership to Improve High Blood Pressure Adherence. Again, that was a study funded by National Heart, Lung, and Blood Institute. A randomized clinical trial with a 2x2 factorial design, 42 primary care physicians and 279 patients with hypertension, 60% of them African American. Again, urban community-based clinics in Baltimore, several federally qualified. And the interventions were directed at both physicians and patients. For physicians, we offered communication skills training on an interactive CD-ROM. It was an individualized program for each physician where they were audio recorded with a standardized patient and then given feedback about their communication strategies with this African American standardized patient with hypertension. The patient intervention was patient activation or coaching by community health workers. So the patients were encouraged to prepare for their visit, write down their concerns and questions. They practiced what questions they would ask and what requests they would make when they went in. And then the community health worker debriefed with them after the initial visit and then followed up with them periodically, like say every 2 months or so for the rest of the year to find out whether they were still actively involved in their care. Now, our main outcomes were patient adherence, blood pressure control, participatory decision-making, and doctor-patient communication. So this is the design of the study. Physicians are randomly assigned to get communication skills training or just to get a newsletter about the hypertension guidelines. And then their patients are then randomly assigned to be coached by a community health worker or to get a monthly newsletter about how to more effectively engage with their doctor and how to manage their blood pressure better. Same here. So you have the most intensive group here where the patients are coached and the doctors are trained. You can look to see whether it matters more whether the doctor got trained or whether the patient got coached. And this group is sort of the minimal group. So you have 4 comparison groups, with the top box being the most intensively exposed group. So what do we find? We actually found, fortunately, that visits of trained physicians when compared to minimal group physicians demonstrated more positive communication change scores. So we found that we can actually change communication. The most intensive group compared to the minimal group showed significantly greater improvements in the patient's ratings of participatory decision-making and information exchange. And then among patients with uncontrolled blood pressure at the beginning of the study, we showed significant reductions in systolic blood pressure in all intervention groups, actually, compared to minimal. So whether the patient got coached or whether the doctor got trained, this led to improvements in systolic blood pressure, and with the greatest improvement for the most intensively exposed group. So I'm going to close with some basic conclusions. Relationship dimensions that are linked to health disparities, healthcare disparities include partnership, communication, concordance, trust, respect, and bias. And there are probably more that we couldn't cover all of them today. We also know that interventions that target improvement of race relationships show promising results, and we need to do more work to see whether, in fact, we could study race relationships in other areas of healthcare and with other types of health professionals. So what are the implications of this work? For research, we need to examine mechanisms by which these relationship dimensions impact clinical decision-making and health outcomes. For health professionals' education, these studies suggest that we really ought to be training physicians and other health professionals in more patient-centered communication and cultural competency training, which includes attention to issues such as awareness of bias and stereotyping. For healthcare delivery, I think this work affirms the importance of equity as essential in quality improvement efforts, the use of care managers or community health workers who can actively engage patients and their families in their care. It suggests the importance of partnering with communities and going to community-based settings to reach these populations, and also the importance of tracking patient-centered outcomes, not just biological measures. And then finally, for policy, this work suggests that it really is important to increase diversity among health and public health professionals. Although we wouldn't aim to match each patient with a concordant provider, we know that when there's diversity within an environment, that it enhances the experiences of all and also increases the cultural competency of the organization. So, and then also the policy implications here suggest the importance of providing resources to strengthen the primary care and safety net provider organizations where many of our ethnic minority patients receive their care. So I'm going to stop there and I'll take questions from you.
So I actually have a comment and a question. So the first relates to the intervention with the study that you showed. I think it's very important that physicians should ask people to come in with questions and symptoms and where do they think the problem started. And then we should also sort of as community members encourage people to come in with a list in case there's something they forget. But my question is, did you ever sort of parcel out your patients and physicians so that you compare the same race, but from, different races from the same socioeconomic level, and then do the same thing with the physicians, where physicians who come from certain backgrounds are compared with how they're treating their patients? Because I'm thinking that may actually be a big difference.
Okay. Well, I'm not sure if I'm going to answer your question exactly, but so in the trial, we haven't actually looked at those kinds of interactions. In some of my observational work, we've looked at things like the educational discrepancy between the doctor and the patient. And we found that actually concordance across a variety of different dimensions contributes to different perceptions and different health outcomes. So race concordance seems to be a major driver of the quality of the interaction, but education concordance also is an important contributor. And it seems like race and education and gender and age and all of these things combined, actually, as you have more concordance on all these social dimensions, you end up having a much better outcome. And this is kind of intuitive, but what it suggests in terms of what we need to do is just kind of more training of health professions to be able to effectively interact across differences, regardless of what they are. Because there's no way that you could ever perfectly get a doctor-patient relationship to be concordant on all these different dimensions.
But I think one of the beauties of Baltimore is that there are a lot of schools. So you have a lot of children, or you have a lot of students who come from the area, but they also go to college. And if you notice, at least when I was there, if you notice, when you go into the doctor's office and you came from a certain background, but you kind of know how to ask certain questions, you do get very different treatment. But
Right.
Sometimes people make some assumptions. And if I don't say anything, then you're going to maybe assume some things about me. And I think that may actually change a lot of things.
Right, I agree. There's so many subconscious beliefs that drive people's behaviors. And so the concordance literature is just kind of right now focusing on things that are visible, that people respond to on a visible level. And I think the findings related to implicit biases maybe give us some indication of why we might find these differences, is because people actually have these subconscious beliefs that are driving their behaviors. One thing I didn't mention is we looked to see whether implicit bias has the same effect on the relationship among Black physicians, patients of Black physicians and white physicians. And what we found was that even though implicit bias tended to affect communication similarly, among Black physicians seeing black patients and white physicians seeing black patients, that black patients actually rated white physicians more poorly when they had bias than they rated black physicians. So we know that there's something from the patient side as well that's contributing.
Hi, thank you, Dr. Cooper, so much for your talk today. I had one question. When looking at your first study, when looking at the different clinician attitudes towards their patients, I think you mentioned that some of the clinicians were within the same practice or in the same environment. And I was wondering if you were able to look at clinicians that worked within the same environment that were of more of a diverse background, how that may have affected the stereotypes within the patients that they served. So if there was a higher diversity within the clinicians, maybe that group had a better outcome for how they treated more of a diverse patient group.
Okay, so I think what you're getting at is kind of the organizational diversity and what impact that has on patient experiences. So we didn't look at it in that particular study, but we have looked at organizational diversity, and we found that actually physicians who have more positive attitudes towards cultural diversity tend to practice in settings where there is more cultural diversity among the individuals practicing and working there, as well as like better attention to cultural diversity by the organization. Now, we don't know whether they select those organizations because they're like that, or whether they actually go there and influence the organization so that it becomes that way. So we know those things are interactive, and we do know that when there's more organizational diversity, that minority patients report better experiences.
Thanks for a super talk, Lisa. You and your colleagues have done a fair amount of work on health literacy. And I've also been impressed recently reading a variety of things, particularly the Vanderbilt group on health numeracy. And I'm just wondering if you have any data, and if not, if you just might speculate either health literacy or numeracy might be either a mediator or a moderator of some of the findings here.
Right. I think that's a very interesting question. And, there's growing work showing that health literacy may be a mediator of many of the racial and ethnic disparities that we see in care, and in particular in communication. So I haven't published my data yet on this, but we have found that there are communication differences among low literate and high literate patients. We still find that there seems to be a race effect that's independent of health literacy level, but some of the earlier work has shown that health literacy actually impacts communication, oral communication, in such a way that these patients actually ask fewer questions. In our study, we actually looked at physician behaviors and patient behaviors separately. We found no differences in what the physicians actually did, but we did find differences in what the patients did. So the low literate patients, similar to the previous work, did ask fewer questions and did make fewer requests. Interestingly, though, we asked the patients whether they would like to be involved in their care, and the low literate patients were just as likely as the adequate literacy patients to say they wanted to be involved in their care. But the physicians actually perceived low literate patients as not wanting to be engaged in care. So it says to me that there's a disconnect between what the physicians think, what the patients want, and what they're actually able to do. So there's a lot of work to be done to intervene in that area.
So on behalf of the NIH community, again, thank you for coming today. And I ask everyone to join us for a reception in the Clinical Center Library.
Thank you. That's nice.